Right. Well, welcome everyone. It's great to have our next meeting for the WONCA Special Interest Group on Policy Advocacy. I'm grateful to my co-chair, Professor Amanda Howe, who's been helping me to drive this process together with some other very interested individuals who I hope are on the call today. I know that Husni Jamal from Malaysia and Sanka from Ranjani Kumar from Sri Lanka have been very supportive in this process. We've had a previous workshop that has looked at some really basic understandings of policy and the way in which we as family physicians may engage in that kind of discourse. How do we actually take things forward? Unfortunately, at our first meeting, I wasn't as well engaged because I was busy in the middle of my own policy advocacy at a very high level in our country, and Amanda carried that day. Thank you very much, Amanda. So today we've got, really pleased to in fact have three, in fact, very leading figures in WONCA, and we're going to try and get them to share some of their insights on some very important topics. So let me just quickly pull up something, and that will help me to engage with it. We've got, who do you think we should go with first, Amanda? I'm sorry, I'm just trying to get the
I think maybe Harris, because when you introduce yourselves, the speakers, and thank you very much for contributing to today. And for colleagues who haven't realized, we have two webinars to try to accommodate different time zones. So it's a big commitment for the speakers, and we're very grateful. So when Harris introduces himself, many people, of course, will know that he is also now the WONCA CEO. So I think he will be able to give some context both to his own experience, but also to the organization. And then Raquel and Sarah are going to give us a particular set of examples working, not just with their context of WONCA, but other ones. So I would suggest that sequence, if that makes sense to the three speakers.
Does that work for you, Harris? So
that's fantastic.
Good, welcome. So great. Let's start with Harris, as Amanda said, the CEO of WONCA, and he's going to talk about communication. I think he's done some really interesting stuff on the WONCA newsletter. So let's start with Harris. Harris, you able to share? I don't know if you want to make the three speakers co-hosts so that they can also share.
I think you're able already to share, but
just to be sure, but you can start. So we're going to have some presentations. We'll see how the time goes in, and then from there we will see if we can have a discussion. It's not in a very large group from what I can see, so we could have a group discussion even now after this. So nice informal meeting, and hopefully we can grow it from there. Thanks. Harris, you okay?
That's fantastic. So good morning, good afternoon, good evening to all of you. My name is Harris Litidakis. I am a family doctor by training, and currently I am the WONCA CEO. Thank you very much for this invitation to Amanda Howe and to Sabir Musa. I'm very delighted to be here and to speak about something that I'm quite passionate about, communication. And I believe that this is in response to an article that I prepared back in September, where I was putting together some elements, some principles of what a good communication should be like. So in the next perhaps 10 to 15 minutes, I will give you a small overview of that. And then we can discuss about the different ways that you can employ such principles in your own context while communicating for advocacy purposes. So when I consider examples of great communication, I find a great approach that a great approach is to think like a scientist and create like an artist. This means that first and foremost, you set up the communication experiment like a scientist in a methodological way, setting out the objectives clearly according to a well-formulated plan, and applying the right foundational knowledge and principles to this plan. Great communication is always consistent and strategic. It should not be it shouldn't have a scattergun approach. It should be aligned with a wider plan, both in terms of the core business of an organization, but also in terms of a specific strategy on communication that your organization may have. And this is really key, because the objectives of communication should be set out in advance. You should start in advance, like a scientist, like when you are preparing for a research. You have to keep these objectives in mind throughout the entire process. This way, we can avoid sharing information for the sake of throwing ourselves into a new shiny communications channel, where practically the means doesn't meet our aims. This is the very essence of what is called also vanity metric. We need to know what we are measuring, and what we are measuring should be important to our purpose. It shouldn't be just a metric that looks good to the others, to the stakeholders to whom you may be reporting, but actually does not help you understand your own performance in a way that informs future actions. An illustration of this, an example of this can be, you can consider perhaps when Twitter was first launched, and many of the brands did not have a strategy. They just joined this shiny new thing, and they were tweeting without clear objectives, without being able to measure clearly the impact of their communication. Another crucial aspect of communication, especially when it is done on behalf or within an organization, and this of course includes WONCA, is that it needs to adhere with organizational policies and wider legal frameworks. This is the basis. This includes policies around privacy and confidentiality requirements, community etiquette, but also branding guidelines and copyright laws. When you're talking within the organization and on behalf of the organization, you're representing the organization. And if it's not explicitly otherwise mentioned. And when communication fails to meet these laws and guidelines, not only can this undermine the integrity and brand perception of an organization, but it can lead to actual legal sanctions, such as the cases of data privacy violations or even copyright violations. Additionally, from the beginning, it is very important to have a strategy on how you are going to develop your feedback and evaluation, so that you outline how the feedback will be gathered, what assessment tools will be used, what criteria will be set to evaluate the effectiveness of what has been tried. I believe that having this in mind from the beginning makes a difference. So these are some key components on which to base a structurally sound plan for communication. And perhaps this serves as a great container for future experimentations. Now, once this groundwork has been laid, the experiment can really begin. Now you are free to really be creative. You can be creative, adaptable, and above all, humble. here is the more artistic side of the work, where you can have space to explore, try new things, observe new perspectives. You can tell stories, powerful stories that can capture your audiences. You can try to be more human in this part, to let ideas percolate and become realized. You can also have some playfulness and even fun with this. And of course, it is very important to combine the artistry and creativity with a more methodological, scientific approach. When you set out ground rules, it doesn't mean that you are going to kill creativity, or you are going to kill that process of creation, of exploration, of being human. When you have both, you need both elements, and both elements need their own space initially to function properly. So you need their own space of the methodological scientific approach by outlining your strategy, but you also need the own space for creativity. Because, to give you an example why this is important, premature judgment, which may derive from applying too early in this process the methodological and scientific approach, can really hinder creativity. When you take all the privacy laws, all the copyright laws, all your methodological approaches, how you are going to measure things, and you apply them from the beginning, then creativity is going to be limited, restricted. So you need to organize a protected space where any ideas are acceptable. Then, when you have a big bag of ideas, then you bring in the scientific part of your approach, and you start making the good calls that will lead you to your best idea. So to that end, there are also some principles that I have found to be helpful in this sort of experiment and adaptation part of this process. First of all, the best communication must be coherent. It should be focused and it should be clear. It should consider the audience that receives it and clarify key points and unpacking, simplifying more complex context. To be professional while also speaking to people in a language that they can understand. And a great example of this are the TEDx talks that are organized all around the world. So you know that TED is a brand, but there is also the independently organized events that are the TEDx events, right? So when you become an organizer for such an event, you receive a guideline, and it is explicitly written that you have to coach all your speakers so that they deliver a script well in advance, at least 2 months before the event, so that you will be able to scrutinize the script, make it understandable to the layperson, take out any terminology, anything that the layperson cannot understand. And this script has to be concise, precise, and also humane. And on top of that, the presentation which will be used needs to look professional. And I would like to give you an example. So Rich Roberts, for example, both Rich Roberts and Anna Stavdal made 2 TEDx talks in the past 3 years. And I would like to invite you to search on YouTube to find their talks. They're quite interesting. And this is actually an invitation to all our leaders, well, first and foremost, you here in this special interest group, to try to see what are the opportunities around the globe to have a talk. Because I believe our messages on family medicine and primary healthcare, the importance of them, will be disseminated very well through this platform. And it will be a very nice experience for you too. You will be discovering many, many things about communication. Now, in our work, this sort of unpacking and simplifying the context, the complex concept means also that we need really to reflect on who we are speaking to, whether they are specialists or lay people, or perhaps other kinds of healthcare professionals. And change, adapt our message accordingly. This is key. We usually have one pitch when we meet our politicians, where we meet the director of our district or the chief medical officer. We usually have one pitch about how good is primary care and how good is family medicine and why they need to invest in us. That's not the ideal solution. We need to study who is our audience and accordingly prepare different pitches where, and as family doctors, we know how to do this because empathy or considering, reflecting on how other people's are feeling and how our peoples are thinking is one of the things that describes our profession. So I would invite you to do exactly this thing when we're talking about communication. Secondly, an excellent starting point for developing an effective communication strategy is to draw from the lean approach, which is so popular with new business, with startups. And as a matter of fact, organizations, non-profits, from charities to social enterprises, have always used the lean startup tricks. Why? Because this is an environment with low resources. Many charities have low resources, few financial resources, very few human resources. What they have in abundance is, of course, the community, the power of the volunteers. But the resources, the practical resources, are usually few. So in such a context, the most valuable currency is knowledge. What I mean by this? I mean that the most valuable currency is what we can learn from our audience. And the fastest, the quickest we can enter in a sort of build, measure, learn circle, the fastest we can learn about our audience, what approach works better to whom. So this lean methodology is so important in communication, in large part because of the need to be highly responsive on how it is being received, on whether it is reaching the right people in the right way. So this is not about minimalism, however. So the fastest you can enter inside a circle is what we could define as the minimum viable campaign. I'm taking a page out of what is called in this methodology the minimum viable product. What does it mean, minimum? It means that our communication campaign can be very, very basic. We don't need the flashy things in order to test a hypothesis. It should be viable, though. It should be sufficient enough. And it should be an actual campaign, something tangible that people can actually see. It is very often difficult to explain something theoretical to your audience, to your stakeholders. You need an actual prototype, which can be as simple as a mock-up of a campaign. In this way, if you create this sort of minimum viable campaign, you will have something to reach very quickly to the build, measure, learn circle. You will be quick to get into that and learn as fast as possible about your audience, what works the best and for whom. So the key here is to keep it as simple as possible from the start. This ensures that you don't put too much energy as well, resources, into this minimum viable campaign, into this strategy or communication output, which ultimately may not resonate with your audience, or it may not have the intended effect. It also makes it easier and lighter to adjust, to iterate, to adapt to new ideas, because you actually have not invested that much in it. So I'd like to give you an example of this. Upwell is an NGO dedicated to spreading awareness and collaboration around ocean cleanups and ocean needs more generally. And they have been employing the lean methodology in their communication strategy. And their basic communication strategy is that we have to focus on the quickest, dirtiest thing that we can get out of the door, so that we can think what is a measurable effect on the conversation. So rather than investing large amounts of resources on new campaigns and having consultants, Upwell runs anywhere to 10 to 20 small campaigns a week. These are small experiments. They are investing minimal resources upfront, and they analyze it. They learn from these campaigns. So just an example of a failed campaign. This is in October of 2012, the United Nations called to an end to ocean grabbing by industrial fishing fleets. So Upwell ran an experimental campaign to support the efforts. And what they did is they wanted to support community fisheries. And they tested a hashtag, ocean grabbing. And they put together the graphics to support and the visuals to support this effort. But what quickly they learned, it was that this campaign was wonky and confusing. So they didn't, and actually because they had clear indicators, the campaign didn't actually spread beyond their immediate network. So this campaign lasted fewer than 24 hours. It is important to be free and to be honest on this. Campaigns or communication strategies or any output can fail. The sooner you acknowledge it, the better may be. So just as with a scientific experiment where a hypothesis is set out, tested, and then the results are collected and assessed, leading to a new hypothesis and a new test, we need to keep reflecting on the learning from our attempts. Now, with all this, I don't mean that I don't want to make the point that organizations do not need to have a communication strategy or a long-term vision. Of course they do. Remember, we said at the beginning, we need the foundations first. So organizations such as WONCA still need to have a long-term vision and a story to go with it, of how they will achieve the big goals and have an impact in the world. Now, the lean startup methodology here actually goes hand in hand with this vision because it creates opportunities for measurement and improvement along the path, the long-term path to that big impact. So in this long-term strategic plan, there is, of course, constant iteration and learning along the way. It's not something that is written in stone and that's it. So ultimately, good communication goes, as you can understand, far beyond just being a pretty story. It affects very crucially the entire operational integrity of an organization, of a cause. It affects, if you do a communication campaign from your clinical practice, from your health center or your local hospital, it affects that facility. Good communication must be strategic, consistent, and focused, while also allowing room for exploration, reflection, and course correction. We need to be able to learn from the mistakes that, or the failures that have been done. So we need also flexibility and adaptation, because they are key parts of this creative process. And as long as we hold, I believe, as long as we hold our core objectives in mind, we have the space to be innovative and adventurous with what we can produce. With this, we will be able to build our brand, increase our engagement to the wider world, share best practices, and have a better impact globally. So I would like to ask some reflection points, perhaps, to invite you to consider what are the principles that you are using in your communication, whether you are a family doctor or general practitioner in his or her own practice, whether you have a more leading position, whether you have a communication within your own team, your own communities, your own organizations, globally, regionally. What are the principles that we are using? And I would like to invite you to also think, what did you learn from campaigns or interactions that may not have worked as planned? It's so key to go back and see what didn't work, to ask yourself, why didn't this work? And then finally, do you have any examples of minimum viable campaigns from your context? Do you have any examples of small campaigns that will that used very little and from which you learned so much? I would be very interested in learning about these experiences from you. Thank you.
Great, thank you very much, Harris. Shabir, shall we have some points give people the chance to perhaps clarify anything with Harris?
Yeah.
So like 2 stages of questions, colleagues. So if you have things you want to understand better, let's have some time on that now, but then we'll go to the second speaker and have the sort of big discussions after that. Is that what you were thinking, Shabir?
Yeah, sounds fine. I think we can give it about 10, 15 minutes.
10 minutes, yeah. So if you can show your hands on the electric. I can see some people. If you want to ask a question, you can put your hand up, and then I will give your name and you can unmute. I'm actually struggling to see on my side any of the hands raised. This is true. So I will clarify one thing, if I may. Harris, thank you so much. That was really interesting, and I've made lots of notes. Hopefully we will be able to share the recording, or if you give permission to share some of the slides on the website afterwards, so that people can see the theory again. But the one thing that I was thinking about was also the recognition of values. So you talked about creativity, but one thing I often think, particularly when we're discussing with people who aren't family doctors or aren't already persuaded about family practice, that it's also useful to understand something about the emotions and the values that are driving them. And that, I think, often comes into the creative space if you have the time, just to have a chat and ask them, how did they get into this and what drives them? You can't do that in a brief period, but in another way, it's sometimes quite revealing. And then you can see the sort of, if it's really money that's driving a group, you've got to have a different conversation than one that is driven by, humanitarian purposes, for example. So within your theory, where does that fit in the process?
This is a fantastic observation, Amanda, and what is important, and you're making the point of why storytelling here is important. So when you're delivering the message, it should be about what the other, the audience, your target user, what are his or her values, reflexes, expectations, aspirations. So one of the most powerful ways to reach out is by stories. Your messages can be conveyed more powerfully and without the use of terminologies and complicated words when you're actually identify a powerful story from within your context and you make the case. They will be able to connect with you because through the story you will be able also to reach out to the common values that you may have with the end user.
Yeah, I would agree. In fact, I think, that's a very powerful way for us to convey things, both in terms of individual interactions, as well as being able to manage it on the online space. So, I mean, just to clarify, I think basically you've gone through talking about the who, and I think that's really important in both these settings. And I think even in terms of the science and the art is actually how do you find the right story. The science is how do you actually concretize that into literally an elevator pitch if you're doing it individually, and how would you kind of measure the outcomes of that. But I think, using this approach you've talked about is more in the space about social media, where we tend to sort of think that we need to communicate also in that, and we feel very intimidated by doing it in that space. And I think Harris has provided some very simple ideas about doing it without making it very, very complicated. One of the things that I think many people get flustered by is that they think that social media requires a whole lot of creativity, and they might be more scientifically inclined, but they feel intimidated by what might be required. And it isn't necessarily that you have to be really that creative to get a simple message across. I think the art, the science is really very important behind the art. And we are relating to patients all the time, where we kind of move away from jargon consciously. We should be applying that, like Harris has guided, to do that in all our interactions, even the president of a country, that you're using stories and being very non-jargonistic about it. But Harris, would you mind sharing some of the things for some of the people here who might not be aware that there are some easy, free resources out there to, in fact, use to sort of become more artistic or to find art easier, more accessible? We have some suggestions around that.
Yeah, so you're absolutely right, and about the comment, you're absolutely right about what you say, that this was more about the who, the how, and the what, because the why should be addressed when you start. You go on with your mission. So you're absolutely right, Sabir. That's a very good comment. There are so many resources. Also, that's an excellent point. There are so many resources out there that are also very much accessible to charities, to nonprofits, or at a very low cost. whether it is Canva for designing graphics, or Envato for your templates and for your graphic assets. There are so many resources out there that you can use to deliver something good. You also perhaps need to consider having a more professional approach. You may need actually to speak with a consultant, right? Raquel. You may need to speak with an expert on this. And there are many experts that could advise you about how to improve your strategy. You can improve your messages, and whether it is a content or from a strategic point of view, how to reach better your audiences. There are consultants, experts that are available around the globe. So you could read on such platforms like Fiverr for business, or Upwork, or Freelancer. So there are many platforms with which you could connect, and they are relatively cheap. Exactly. Of course, you need to be careful with what what the expert advice you will. Yeah, you need to be a little bit careful with identifying the right expert for your needs, but knowledge is accessible and consultancy is accessible.
And I guess that maybe is, I mean, a difficult decision for WONCA executive with budgets, because to invest in even one resource, and then, as you say, if that isn't effective, then another one, then another one. At the same time, I think one of the purposes of, Ozden, well done. You've been trying to get on for a long time. I've been seeing you go round and round, poor thing. Anyway, the thing that I think often we need to be discussing with our members and our regions is what we can do centrally, because at least we have some budget and some expertise in the executive that can then hold things together. And at the same time, obviously trying also to make that decision in our local or our regional, national groups, to try to set some asset aside, but we are mostly volunteers. And so, you know, that is also complex, isn't it? In another way, colleagues, that's why this group exists, because if we have some of the expertise, we may be able to be more effective if we are the advocates, rather than having to employ other people, which usually we can't do. So anyway.
Well, good. You know, interestingly, and before we get to Raquel, these are actually very relatively cheap and easy to do. And in fact, I'm sure that Harris is already using them. The difficulty is, I think it becomes a dependency problem. We depend then on the small staffing to actually help us do it. And I think that just like we struggle today with the Zoom call, there is a bit of a human resource problem. And I think if we as volunteers just look at these resources, we may find that they are very available to us in all sorts of respects, not just in WONCA work, in our practices, in our regional or local organizations. So I would strongly urge to try and look into these resources and see how you can use them.
And Sarah's just shared one that she's found useful as a, ideas and resources. So thanks. Cool.
Good. Thanks, Sarah. Raquel, go ahead.
Yes, I want to say thank you, Harris, for your fantastic presentation. You really make everything look very simple, although it is not. And for sure, you were mentioning the strategy, and when you set up the strategy, you need to measure it. And I hope maybe for the future webinars, how to measure our how successful was our strategy will be a very good topic. And there I wanted to make the point, because for sure we need for that professional advice, and not everybody can allow in their organization to have this professional advice. So it would be great to know how we can tailor our strategy for our budget or for the different situation in low and middle income countries, and to see how our strategy and the impact of our campaign has permeability or impact. So that I will really be keen on see how you elaborate this a little bit. Thank you.
Go ahead, Harris, do you want to respond to that? And any other comments or questions, feel free to raise your hand before we move on. Okay, go ahead.
Of course, Raquel, you're absolutely right. We need to be able to provide key advice on how to measure our the efforts within WONCA, and I'm speaking about WONCA, considering all the regions, the working parties, special interest groups, all the communities, also the communities of practice that are created informally within WONCA. And I believe, well, on one hand, there are two things. The first one is that as Secretariat, we are very happy to provide support on communication strategy. We have few resources, as Sabir was mentioning, but we are trying to put them in to the best of use and to the best of interest of the organization. So if you have questions about how you could perhaps improve your messages, or how would you measure a campaign, what indicators you should use that are not just vanity metrics, then why don't you're very, very welcome to reach out to both me and Maria Dolores Zavala, who is our communication officer, and we will be very happy to have a chat with you. So that's one. The second part is that as with context with restricted resources, there is what is called frugal innovation, right? So in order to solve something that you have scarcity, that you don't have, you go and think out of the box to use something that you have in abundance. And for WONCA, what is this? It's the community. So, and this is a broader invitation. This is our main asset as WONCA. It's our community, in addition to the increasing brand recognition. But our community can come up with ideas, come up with other examples that are easily transferable from context to context. So an invitation would be that now that our groups, our online groups on the membership portal are being launched, would be to ask our colleagues, please share stories from your context. Let us know what worked, what failed. This may become a source of inspiration of how you set up your own campaign, and what kind of indicators you used, how you measure things, and how what you have learned from your outcome.
Thank you. That's a great segue into our next presentation. Actually, I think Raquel and Sarah are going to share examples of it. And if I may say, I think that we also need to know that these are also quite accessible. I mean, don't need to go all over the show. If you just take Twitter as an example, or Facebook, you can in fact find simple measures that are available to you on what's going on, whether it's friends or likes or whatever. So it's not impossible to get a sense of your communication strategy, even using the things you use every day. So take the simple things and think this through. What has been presented is think the messaging through and look at what you can do, even in your own little social circumstance, where you can measure what has exactly happened. So I think this can grow into bigger things. Thank you to Raquel and Sarah. Raquel, do you want to start? And then Sarah, how will you do it?
Yes,
okay,
sure.
Raquel?
Yeah, thank you so much for the invitation and the opportunity to be here. Sarah will share the presentation. I just wanted to introduce briefly. I'm Raquel Gomez Bravo. I'm originally from Spain, where I did my medical training. but now I'm working in Luxembourg. I'm also the chair of the WONCA special, the co-chair of the WONCA Special Interest Group on Family Violence, and I share a lot of interest. So I will tell you how this story started of advocacy. In the 17th of November 2020, our national organization, CENFIC, Spanish Society of Family Medicine, was inviting us, Sarah Pilar Astier, who is also a member of the WONCA executive, WONCA World Executive, the former officer of the society in WONCA Europe, Jose Miguel Bueno, and the vice president, Maria. They were inviting us to write an article or editorial where we were explaining how primary care was handling the pandemic in Europe. So the scientific society was identifying key people and putting them together to provide evidence, to publish a paper in Spanish, where we were underlining our important role. So that was the starting of the story. So they were putting us together, and then the magic happens, because then these people together were just brainstorming how could we give visibility to primary care, how we can influence others, how can we influence policymakers, how could we reach other level. So from that invitation to write an article that they were very kindly covering the fees, was coming up a research study and a strategy that Sarah will present you. Sarah is also my colleague. She was also, and now she's working in Madrid, where I was working previously. And she's the representative member of CENFIC, of the Spanish Society, in EGPRN, the European network, the research network of WONCA Europe. So that's why we have this liaison. So now I give the floor to Sarah to show you how the story was evolving. Thank you so much, Sarah, for your time. I know you have a very difficult time now in Spain with the strikes and so on, so we even value much more your participation today.
So thank you so much. It's just my pleasure to be here with you all. It's also very interesting to have to listen Harris before, so I'm not very sure if we have communicate the strategy very well. So I really hope, Harris, your feedback after listening to you, but thank you so much for sharing your presentation. It was very interesting. And so I wanted to share a little bit about what we have been working, and we will be very happy to discuss with you later all your comments. We are learning and we want to improve and to make the things as better as possible. So thank you so much. I'm gonna just share my screen. So wait, let me see what's okay, here we are. So I think, let's see. Okay, so I think everybody's seen my screen, I guess, yeah. So we're gonna talk a little bit about primary care and the European Union policies. If you listen to me saying EU, that means the European Union, to those of you who are not based in Europe. And especially thank you to all of you who are in the East, and it's good evening for you, so thank you so much. And we really want to focus and analyze a little bit about what happened in COVID in Europe, and in general, probably you can have some kind of lessons that you can, you know, resemble to your situation in your country. And so we're gonna talk a little bit about an introduction. I'm gonna tell you a little bit about a project that we have been working in the last 1 year, 1.5 years. We're gonna share a little bit about the visibility of primary care during the pandemic and how to be involved in the EU policy. So that's more or less the contents we're gonna share today. And first, I want to give you a little bit of introduction. So why Raquel and me are doing this? Because actually we finished the paper and it's published. So, you know, our collaboration should have stopped, but, you know, we are still there working in this topic. So I think that everybody recognizes, especially those who are here in this workshop, is that most of COVID cases, fortunately, they were mild cases, so they don't really need to be admitted at the hospital and they don't have complications. And many of these patients were treated in primary care. And so that's something that all of us know, but it's not something that is very well known in general, because, you know, some part of the media didn't focus in what happened in primary care. And on the other hand, you know, our politicians, they are, you know, very fascinated by hospitals and by technology, but they are not very fascinated by the doctor and patient relationship in a primary care setting. And so we realized in Europe that most of GPs, they were very tired. They have been working lots of hours and they really need help to improve the care of their patients. And so when we listened that the European Union gave an extra budget to fight COVID, we thought that's very good news. You know, we really need this extra budget. We really need to hire more people. We really need more support to do the things better for our patients. But, you know, all the good news, they always have a bad news or a bad side of the news. And the bad side was that, you know, primary care was not in budget. And, you know, the role of primary care was very, you know, little in the EU COVID strategy to fight COVID. So we thought, this is a little bit, you know, strange. We were not obviously very happy, but so we decided, okay, let's gonna do some research. Let's gonna describe what happens in Europe. So we found, and I want to show you this picture because I think it's quite clear. These are the data from 30 European countries. You know, we have like 24 EU countries and 6 non-EU countries, but we found that 49 millions that they represent the total cases. So this is like the blue spot, that is the biggest spot. So they were treating, you know, ambulatory. Then we have nearly 2 million of patients who were hospitalized and admitted at hospitals. We have about 300,000 patients who were admitted at the intensive care. And unfortunately, we have nearly 700,000 patients who died. But as you can see here, most of patients, they were treated outside the hospital. They were not treated inside the hospital. But, you know, it looks like treating people outside the hospital was not a priority for the EU. And so that was something that it really, you know, make us think, how could we do things in a different way? Or what was happening in Europe? We were crazy treating 49 million patients, and it was not enough to anybody to see that kind of hard work. So that was, you know, our concern. And so we decided that maybe we could do something or try to move a little bit about that. So I just want to also give you a little bit of key numbers. You know, we found in the observatory, in the European Observatory on Health Systems and Policy, on Policies this data. So they said that in Germany in 2020, 85% of COVID cases were treated ambulatory, and the number rose to 95% in 2021. In Italy, we have like 156 patients who were treated at home from every 100,000 patients. So, you know, it's not just the numbers that I showed you before, is that this was really happening. You know, it was not in our imagination. It was something that it was measured and that we could say that happened. So we decided to do a study. So because we are part of the European General Practice Research Network of WONCA Europe, so we have many contacts and many friends. So that was very nice. And so we share, you know, this reflection that we were having on our own, and then we share it, you know, with 52 researchers from 30 different countries. And, you know, we found that everybody had the same thought. So that was quite fascinating. It was not like, you know, we were a little bit crazy about what happened in Spain, and maybe we have, you know, a biased perspective of what was happening in Europe. It was like everybody in all the countries, they have the same feeling and they have the same experience. And so we thought we must do something about that. So we decided to launch a study to understand what happened in Europe and what was the situation, to be able to analyze the strategies to try to improve these circumstances. So I'm going to show you a little bit of our results and a little bit about what we found. So these are the countries that we were working with. As you can see, it's lots of countries. So it's not just like, you know, 2-3 countries. So we have 30 countries in Europe. And so we did an initial questionnaire with some questions about how was the process of treating and of attending COVID patients. So we asked about how was the testing, how was the tracking, how was the diagnosis, and how was the follow-up of these COVID patients in Europe. And so we did some consensus, then we collect data. So we have a team of 2-3 GPs in each country. They did a peer review of the collection of the data they found in their own countries. Then we made a international peer review of this data. And then we have a final consensus about the data and the findings that we found. And that's a little bit what I'm going to share here. We have now 3 papers under review. So I hope that maybe you can read a little bit from us in the next months. I hope it's not going to be very far away, but probably you're going to listen or read a little bit about us in the short future. So what was our main results? So we found that in Europe, primary care was involved in nearly all the steps to treat COVID patients. So we were detecting cases and we were testing patients. We were managing these cases. We were providing initial medical care. We were providing follow-up. We decided whose patient was not doing very well and they need to be admitted at the hospital, and those ones who could be at their homes and they could be monitored at home. We also did all the sick leave allocations from all these countries. And we found also that, the way that we approach COVID, it was different in all these 30 countries. I also want to share a few words about the long-term care facilities. So, that nursing homes, there was a key sad situation in Europe because many patients, they die in the nursing homes without the proper care that they needed. And so we found that some of our GP colleagues, they were really worried about the nursing homes, and they have done a very important work in treating these patients and in caring these patients. So we found that GPs, they were doing something like half hospitalization in the nursing cares, but nobody was nearly talking about their role, and that was quite relevant. We found some colleagues, in Slovenia and some colleagues in Italy who have been working very, very hard, and they don't have all the resources that they need, but they did the best. And so they told us that we should also talk a little bit about that. So you can see in the dark blue, the countries who were really involved in treating patients in the long-term care facilities. So it's something that we don't really talk about, but I think it's something that we should remember or keep in mind about that primary care is not only outpatients, it's just like everybody who's in the community as the nursing homes. And so nursing home patients can be healthy or half healthy, we could say, or they can really need us. And so I really would like to say that, so many countries, they were doing a very good job in the nursing homes, and this job has not, go together with more resources to these GPs who have been working in these locations. And so I want to share the good news, so what happened, what our European GPs were doing in general in primary care. So 27 countries, they were performing the COVID testing in primary care, which is quite amazing, honestly, that nearly all patients could be treated ambulatory, close to their homes, with the GP and with a nurse that they know from all their lives, which is lovely. The other thing that it was also a revolution that all of you are aware of it is like we started using phone calls and video consultation to treat patients. So remote assessments in primary care was really implemented. It depends a little bit of the countries, but in general, all the countries change without nearly no problems. And if they have problems, they really, go ahead and keep giving the care to all these COVID patients in the community. And we also found that it was very important to have some social support. You have to isolate and you need resources to isolate. So 25 countries, they offer social support to these patients, which is a very good number of countries. Obviously, it should be all the countries, but at least it's something. And I think that's quite important. And I would say these are the main rich milestones we found in our study. But unfortunately, there are always missed opportunities. And we found some inequalities, and that was a little bit hard to listen. First, we found there were no consensus in the isolation length in Europe. And this is quite funny, I would say, because everybody agrees isolation was very important. But we found that the WHO guidelines for doing isolation and the ECDC guidelines to do isolation, they were not properly followed by the majority of countries. And actually, the countries didn't agree about the isolation criteria. Maybe you could tell me, well, Sarah, maybe countries who are neighbors, they agree about the criteria. That will be lovely. But, neighboring countries, they did not agree about the isolation length. And so this is quite interesting because, you know, everybody has the same information and everybody took different decisions to implement that kind of information. And I think isolation length should not be so difficult to decide together, but we could not make it together. And this is something that is very sad. And I think it has a big problem if we want that, you know, the society's trust on science. How can you trust in sciences if we are giving different message and all of us have to follow different message? And if you travel a little bit from one country to another country, especially in the second part of the pandemic, so you will have to follow different guidelines, which is confusing, or at least I find a little bit confusing. We can discuss it later, but I just want to say that. The other thing that we found is like, you know, if you have COVID and you have to isolate, obviously you have to stay at home. I know that sounds quite revolutionary, but it's how it is. The problem is that, you know, GP, they have to manage 6 leaves in 21 countries. And so, you know, manage all the administrative work to do sick leaves. It's a big work. When we were lacking staff, we don't have enough doctors to treat all these 49 million patients. And then we have GPs making papers so patients could stay at home. And so I just want to ask you, and we can discuss later, that if this is the best way to spend doctors' time to treat patients in a health emergency. And nobody has said anything about that, and we are worried about that. The other things we found is like chest X-ray was available only in 18 countries. So you know that the main complication of COVID was having pneumonia. You also know that pneumonia, if it was unilateral, could be treated maybe in the community, but if it was bilateral, in some cases you have to be admitted. And unfortunately, that was the main point. So many people, they have complications and eventually some of them, they die. So, you know, having the possibility, you know, to rule out pneumonia in the community was a keystone to be able to treat patients in the community. So 12 countries in Europe, they don't have the chance to do it. So if you want to rule out pneumonia, you have to send patients to the hospital, and the hospital, as everybody knows, they were not in the best situation at the moment. We also have problems with the blood test. You know, blood test was only available in 23 countries. So if you were thinking that maybe some patient could need a blood test, you could not ask for it in all the countries. And then we have another topic that we haven't talked or we haven't shared is like heparin and oxygen, that, as you know, it was proof in the second part of the pandemic that it was part of the basic treatment to these patients who were a little bit more ill. It was not available in it was only available in 21 countries. So that means that you could not prescribe oxygen in the community, even if you were working in countries where maybe you were in the nursing homes giving care to these patients. So, you know, we found that there were inequalities in how to avoid and how to treat these patients in primary care. But it was not only about the treatment. We also have a question. Is primary care existing in the pandemic in Europe? Do we have data from what's going on in the community in Europe? And so, you know, we make a question to all these 30 countries. And so we asked them, do you have primary care indicators regarding the COVID pandemic? Any indicator? We were very open. We just collect all the possible information. And we found that only 13 countries collect any kind of information. I just want to tell you that the ECDC, the European CDC, is not collecting any primary care activity. And also the WHO dashboard is not collecting any kind of primary care activity. But maybe you were thinking, okay, if 13 countries are collecting information, I'm sure they're going to collect the same information. That was, you know, our ideal situation. But unfortunately, it doesn't happen like that. So we found 13 countries, they decided to collect 40 different indicators. And when I'm saying they are different indicators, I really mean they were very different indicators. It was very difficult to compare and to have, you know, an idea about what happened. Some countries, they decided just to collect the number of sick leaves. And other countries, they decided to collect the number of tests from primary care. And other countries, they decided to to count the number of x-rays or follow-up by the nurse, follow-up by the GP. So, you know, a different mess of indicators, which was a little bit confusing. How would we compare all these countries if we were not measuring the same stuff? Actually, you know, we just found that the most common indicator, it was only collected in 5 countries. And it was the total number of cases in the community, of COVID cases in the community. And it was only in these 5 countries. So if you want today to compare what happened in primary care in the community in Europe, you only can compare 5 countries. And as you know, we have more than 5 countries in Europe. So that's not a very new news. So, you know, you can see in the dark blue, which were the countries who have this, you know, sensibility to collect this data from the community. And you can see in yellow, these countries who were not really collecting data from the community. So if you have some doubts, this is more or less the map about what was going on. So I just wanna give some conclusions of our study. So first, sick leaves, there were little change to simplify the way that we were making sick leaves. And we were spending time that probably could be spent in another way. So we have problems with data. You know, we have poor visibility of primary care data, and we have such mass heterogeneity with the indicators that it was very difficult to compare anything. We have an unequal access to complementary tests and treatments in Europe. And the thing is that most of COVID cases, 49 million of patients were treated in primary care. That's what happened. And we found that we should think a little bit how to change these numbers and how could we do something with these conclusions of our study. And so I want to talk a little bit about policies and, you know, how can we share what we learn and how things could be in a different situation. So I just want to say that the European Union, we have 44.6 million of citizens. Now we have 27 countries. We really miss UK, but we love them anyway. And it's also important to say that we learned with the pandemic that it's not only the EU or the European Union. It's about everybody who's living in Europe, because the pandemic is not something about some countries. It's something about all of us across the world. And so we should have, you know, a much more open mind to tackle and to look for solutions for the pandemic. And we should reflect together and make things together and have shared policies together so we can really give a clear message to the population and we can really improve the resources needed to treat these patients in the community. So to those of you who are not from the EU, you know, we have a Charter of Fundamental Rights, which is something that is really needed and very important. And I'm just going to read a little bit of one of the articles, that is Article 35. And, you know, our European Constitution, they say everyone has the right of access to preventive healthcare and the right to benefit from medical treatment under the conditions established by national law and practice. A high level of human health protection shall be ensured in the definition and implementation of all union policies and activities. And obviously you read this sentence and I think everybody here agrees. So if we agree about the sentence, that is quite important. So why don't we see that this sentence is real with the problems that we are facing at the moment? And that's a little bit that what we want to share, how to make this sentence make sense on the ground. So, you know, in the role of the European Union in the pandemic, they decided to launch a program which is called the EU for Health, that it has a budget of 5.3 billion of euros. I'm going to repeat it because it's much more money than I can manage on my head, you know, but 5.3 billion of euros and nowhere for primary care who treated 49 millions of patients, you know. So it's just something that, you know, this cognitive dissonance should be with us when we are reading this. And so the program is going to be implemented from 21 till 27. And so I want to share, this is one of the screens from the EU to explain how the health program is going on. And, you know, the health program, I'm going to explain you a little bit later why we decided or how it's the agreement to get to this point. But, the strands of action and the #1 priority of the EU is not COVID, it's cancer, which is okay. We don't have to have a priority of COVID everywhere. And so, they don't say much about COVID, which is quite interesting if this program has been launched after COVID. But okay, we can just buy the idea of cancer. And I think everybody agrees cancer is a big problem and we should work together to handle it and to improve the care and the diagnosis and the treatment to those patients. And so they have a strategy where they are saying that they want to improve and foster health, they want to protect people, they want to improve the access to treatments and medical device, and they also wanted to strengthen the health data. And you can see some blue signs that I have put to share where primary care could be in this strategy that has been promoted and is being implemented in the EU. So I think that, as everybody knows, we as GPs are working in health promotion and disease prevention. We are also working in prevention and preparedness and response to cross-border health threats, because we have to work together, but also because Europeans, they love traveling. And so we see patients from all these countries in different places. And that's something that is also part of our European culture. And we also have to talk about the strengthening the health data, the digital tools and service. So when we are talking about strengthening health data, so that also means primary care data, or it should mean primary care data. So, I think that primary care has a role in this program, or should have a role in this program. So, our values can be really integrated in this program. However, we found that in the pandemic in general, the COVID data was not collected from the European CDC, which is a pity. Also, we have a very nice website with the COVID vaccination. So you can compare how COVID vaccination is going in Europe. And also some of the COVID vaccination is happening in primary care. And there is no role of primary care in the vaccination tracker from the ECDC. So we are doing the vaccination, especially to elderly people and vulnerable patients, but we don't exist for the ECDC or the European Union. But also we have this COVID passport that was implemented to be able to travel, and in some regions to be able to attend to some social activities. And so primary care helped to get these COVID passports in some countries, and especially they had to get it to vulnerable patients, but there is nowhere to say that primary care was doing this work. And as I'm also giving you very good news at the moment that, all the results are negative, but we have, fortunately, the OECD, they have this lovely journal that is Health at a Glance. And so they share indicators and they share some aspects of how health is organized and how health is provided to European patients and patients who are living in the OECD area. And so they were very nice, and I have to say it here very clearly, they were super nice. And so they were collecting data from GP consultations during the pandemic. And so they decided to collect face-to-face appointments and remote assessments. Also in Europe, that I didn't collect in this screen, but we also have the European Observatory on Health Systems and Policies, which is led by a GP, which is very good news for us. And so, they really compare what happened in Europe in the different countries. And, they usually talk a little bit about primary care. But unfortunately, you have to read all the things that they have written to find primary care, So in some countries, you really can find very easily information from primary care. But in other countries, you cannot find anywhere about primary care. So this is the visibility of the pandemic. And I'm asking you again, it's fair to have this visibility with 49 million of patients attended in primary care? Is it, truth? Because, we are living now in a fake news world, and it looks like, we are not anywhere, even not in the fake news. That doesn't mean that I agree about the fake news, but I want to tell you that we don't really exist in all this picture, and that's quite important. So the question is how primary care could be involved in the EU. So the EU, they are very smart. So they have this website where you can see how the EU and the EU policies are influencing in a normal citizen. And so they have, you know, one of the part of the websites, they talk a little bit about health and what's going on with health. And so we have the EU regulation and funding and how to support the national healthcare systems. So I want to give you a little bit of feedback about how the EU for Health program that is now focused on cancer, how it's working. So they have like the stakeholders, and that's really important because the EU in the law, they say that it's very important to take and to listen to stakeholders and representatives of civil society and patients' organizations. So, you know, they are really interested in listening to us. And, you know, we are representatives of all the GPs in Europe. So for them, our organization as WONCA Europe and WONCA World will be very welcome to be a stakeholder. So by the European law, they have to do every single year a public consultation to these stakeholders to be able to share their opinions in health and how health was provided in Europe. So they have not only to do the public consultation, that could be, okay, it's fine. The public consultation generally is a survey. The survey is, well, you have to answer with lots of questions and it takes time to answer them. And then once they have all these stakeholders' opinions, so they make a report and they share the report with the European Commission. And the European Commission then work with this report and with this idea. So they see how they can implement all this idea, you know, and they can really make that this idea get to the civil society. And so, you know, not just the stakeholders, but all of us who are working in health could really, you know, be doing and working something for the patients. And once they have an agreement in the European Commission, so this agreement, they goes to the European Parliament. And if the European Parliament agrees about the report from the European Commission, so they say, okay, we're gonna invest, you know, lots of money in doing these policies really real. So the thing is that they really listen to the stakeholders. And, you know, it's very nice because they listen to the stakeholders every single year. So, you know, don't worry if we have not been participating in the past, because we always have the chance to participate in the next year. And, you know, you really can register as a stakeholder. Raquel and me have helped WONCA Europe to be registered in the stakeholders. And, you know, we share our opinion in the last health public consultations. I also want to tell you, if you are outside the EU, you are also very welcome to participate. You know, they're going to ask you, are you in the EU or outside in the EU? But, you know, you cannot take any of these answers, and then, you know, you can really share and give your opinion about the public consultation. This is really important because they also have questions about how the EU should have relationship with organizations and countries outside the EU. So it's really important, you know, to participate in this program. So I want to give you a little bit of feedback of the last stakeholders consultation. So they have like 322 stakeholders who answer the survey. So we have 5% of answers came from Belgium, which is quite interesting because it means that Belgium is really lobbying the EU to get their idea. So it's a very good, you know, news and decision that WONCA Well has the main office in Belgium. So thank you so much for taking this decision. This is really important for GPs across the world, I would say. And, you know, the news is like only 15% of stakeholders were healthcare organizations. So I'm going to ask you, what will happen if all the national WONCA organizations were participating as stakeholders? Because we are many. Could you imagine that 80 organizations, national WONCA organizations, were answering this survey? So we will be a big percent of the answers. And so our ideas can be shared in the European Commission, and maybe we can make some changes or start making some changes. So, you know, in the 2023 survey, so the main topics that they share, it was a health promotion and disease prevention, which is primary care. I'm not very sure why they did not write primary care instead of health promotion and disease prevention. On the second most important topic, it was health system and healthcare workers. And then later we have digital health and cancer, which is quite funny because at the end, cancer was the main point from the EU priority, But when they were asking the health, the stakeholders, they said that health promotion and disease prevention. So, you know, the European Commission also have their opinions, and obviously they just put the focus in one topic, which is all right. But I want to tell you that, you know, we are part of these answers, and primary care has an opinion of these answers, and it would be a very good opportunity to participate in the service and to say what is our role in all these topics, because we actually have a role, we have work, we have research, and we are working every single day with patients on the ground. So I would say, what could be the role of primary care in the European Union? And we would like that, you know, WONCA in general, national organizations could be and stakeholders in all the surveys. We could participate in all the surveys. You know, the European CDC, the EMEA, that is the treatments, the medication association to, it's like the FDA in the States. So, you know, these organizations, they have the possibility to be observers. So you can give your opinion, you know, obviously they are gonna just listen to you, but they listen to you. So it would be very nice if we could be observers in the health organizations inside the EU. And on the other hand, it would be very nice if they could listen to primary care data. I would say that will be very important to listen what happened in primary care. But obviously, you know, it's okay to have short-term, you know, ideas, but we would like to share a little bit about long-term roles of primary care in the EU. So I think universal healthcare is something that is very important for WONCA and for all of us. Also that it would be very nice to be able to share healthcare service across the EU. It was very important. It would be very nice if, you know, the EU could be funding all the primary care preventive service. If they say that preventive services are so important, so it would be very nice that we could be the one who have the resources to provide preventive care to all the patients, because actually we are doing this work for free at the moment. So, you know, it would be very nice if we have more resources in that part. On the other hand, it would also be very nice if we could be participating in decision-maker bodies in the European Commission. And obviously, we would love that the EU legislation could protect primary care and the values of all these other opinions and of all these other national parties that not all the time they are protecting primary care. And another thing that it's a problem here is just to keep primary care workforce. You know, if the workload is so high, so GPs don't want to be working in such a stressful place. So it would be nice if we could have more resources so we could keep and give the ideal conditions to be able to work in primary care. And so just to summarize and end my presentation, I just want to say primary care is a key agent to provide care in the EU. And it would be very nice if we could really have all the resources to do this. I'm going to give a small announcement, because as I share with you that we have all these different indicators regarding COVID, Raquel and me are working in a Delphi consensus. And so we are launching a Delphi study. So if you are working in Europe and you could answer and rate all these different indicators we found to make a consensus of a set of indicators and how to measure COVID in Europe and how to measure the next pandemic, whenever it is, we will be very happy if you could give us your time. So if you want to write an email, or if you now want to write your email in the chat, so we can make you send you an email so you can have the information of this Delphi study, and we will be very honored to have your participation and your opinion on it. And I just want to say thank you to everybody. And we also would like to say thank you especially to the people from WONCA Europe, to the President Slomo Vinker and the elected President Thomas Fries for their support in this initiative. And I'm very grateful for all of you who are still here after I'm finishing this presentation. So thank you so much to everybody.
Thank you very much, Sarah and Raquel. Appreciate that very much. It was an excellent presentation. I think you know, the message that came to me was the importance of reflecting on numbers, and I think you took what was publicly available and actually reflected on it, and then went through collecting it from small practices. You know, 52 practitioners in 30 countries to basically develop something very useful insights. I think the question I would have, I think, is, was there any shift in policy? Actually, I know you talked about trying to reach into the policy space through, the stakeholder survey, observers, and data. I think what would be useful to get clarity about is, did it shift anything? I think it also, for me, raises the possibility of regional special interest groups and policy advocacy being formed that would then work with the executive committees to say, these are important issues. Can we feed you information? Can we work with you to actually advocate or help you advocate? I think one of the key things is we need to also do this very closely with our regional execs and national global execs. So thanks for that. Wonderful stuff. And if any others have some views or thoughts or comments or questions, please feel free to raise your hands.
Yeah, I just wanted to
go add on before
some summary as well. Thank you very much, Sarah and Raquel, for inviting Sarah and making us aware of this work, and Shabir for the comments. I mean, it's actually quite complex, but if we go back to where Harris spoke, the things that I thought helped you was, first of all, we had a previous infrastructure. We had the European General Practice Research Network. Not all the regions have that, although they may have some equivalent with academic groups. But I think because that already existed, and we had a group of motivated and expert individuals, then in spite of the pandemic, or because of the pandemic, actually people did this work. And so one of the challenges in WONCA, if we were doing a follow-up to the webinar, would be, do you have that? Could you do that? How could you do it? Then, as you said, and Shabir just pointed out, you saw the evidence gap and you built a good research project around it. And we do have a working party on research in WONCA. And again, it's an existing infrastructure, which has also collected some data, for example. So I think WONCA, we can go on discovering that. But then the other things you showed later were the knowledge of those other structures that you might be able to advocate through, including the legal documents, and that's quite an expertise. Previous partnerships, so we've worked in WONCA Europe, in WONCA with OECD for a long time. I did quite a lot when I was president. And so I think, again, having some allies who will hear our voice when we start to say, we've got these data, is really important. Different ways to give the message. You're publishing, you're appealing to us to talk about how we can use it for advocacy, but also showing us the places that we can feed in the future, like the EU survey and consultation stuff. And then I think we also can use this as a very good example to say, well, if you've got these data, how would we use it? And you've started that discussion. But the things, again, that Harry said about, who do you communicate and how with? When you've got those data, it's a really good workshop kind of example. So WONCA Europe and WONCA Sydney still open. Hopefully we could maybe build an application in with that. Thank you.
Well, thank you so much, Amanda, for your comments. I will just say that for us, it was quite interesting to see that, all the countries in Europe could prescribe oxygen and heparin. And that was a key aspect because, each of these countries, they could say the national organizations that they could not prescribe, but everyone else could. So that was something very important. So I think that sometimes when we're thinking in policies, we are thinking like in a big picture, and we forget that there are some small countries that they also need support. And it's also important to give data and to say you have the right to ask for something else. And I think that's one of the key aspects to being WONCA, because we can have this shared information and then we can go together to say this is not fair and there is no medical, argument to say you cannot prescribe oxygen or heparin in the community. That's just an example, but it really have these countries to be able to advocate in their own country to improve that in primary care. So I think that's something very important. And sometimes we can influence in general, and other times we really can go in small aspects where it's also needed to make some change. And so it was interesting for us to support this national college who were struggling with those aspects in their countries.
Yeah.
Özden made a point about the question of how we could use the data with looking at vaccine refusers. I don't know whether you want to dwell on that question, Özden, in the discussion.
Well, it was an example when we are talking about stakeholders. Not only the stakeholder will be us for WONCA, let me say, it will be us. And it was interesting in Turkey that when you just say that you want vaccine, you can just make protests and so on. But you may do that in Istanbul, and they just got it because they got the permission. This was something that has got two faces. That's why I asked, when the policy thinks that this will be useful for their policy, they could just listen to you. But if it's not, maybe they wouldn't. So that was to make the situation a little bit hotter. If the patients just say they just don't want to get vaccinated, what would we do as a stakeholder? So we will need the evidence-based data. And thank you very much, Raquel and Sarah, you just give us that. And also in Turkey, like the other European countries, if something just goes with policy, you just have to go court for the malpractice. Also, you need guidelines. And you need evidences, and this should be just global citizen guidelines, not only local. And this evidence could also give us this tool, and also could be a shield for us, for the general practice and family physicians to use this science-based evidence with data for our patients, and also for us for prevention, and also to improve our health policies. Thank you very much. That was the question. For that reason, if the words and the stakeholders are not in our opinion, what should we do? And also, if the policy didn't listen to us, for example, in Turkey, for the first prevention times, they couldn't find enough primary care worker, although there were. They used dentists to just look out of the home care services, and some of them has just died because they haven't got enough equipment. Now it is improved, and everybody just forgets lots of things because new challenges is coming, but it should be documented. Thank you very much.
So
Thank you, Özden. Perhaps Sarah and Raquel could respond to that question.
I would say in general, obviously, there will always be stakeholders that they have a different opinions than we have. But if we don't exist, so there's going to be the main opinion. So, I think the point is not to make an agreement with all the stakeholders, just to share our perspective and to understand that everybody has the right to be listened, even if we don't agree. And the other thing I would say about the second question is that I think it's important just to work together with another organizations and another groups to understand each other and to see how we can work together. And I would also say it's important to say, that evidence medicine should be, in general, the gold standard. And so if we are sharing this message, no, but we have to share it together, time by time. So there is a moment where it's just like, this is the real life. And obviously, we are going to face many challenges, but I think that even if we are finding challenges, we also can learn and improve our strategy, as Harris has shared before. And, I think that we should not be discouraged for these groups who are advocating for things that are not good for the general population. We should be there and try to have, a voice who is open to listen, who is also open and gentle in their answers, how we answer, and to be persistent, because I'm thinking about the example of
water and the rock.
Yeah, and I think
sustainability will just find a way. Yes, I precisely agree with you.
Yeah, thank you so
Wonderful,
much.
Sarah. All the best practice of a good advocate. Raquel, go ahead.
Yes, thank you so much for your comments. We have been working together, like I said, during these 2 years. We have a deep knowledge of the structure, like Amanda was saying. So that was helping us to use it. And as Harris also mentioned, one of the biggest values of WONCA is the human resources. We are a lot of people. So if we are organized and a structure, we can set up a strategy. And that was helping us when we were discussing our frustration on how COVID pandemic was shown in the media. We're speaking about the numbers of beds in hospitals and how the news were arriving to the population. There was a big part missing. It was primary care, and we thought that was part of our responsibility to collect the numbers, to provide evidence. And then the next step is how we use this evidence for advocating, and how we can really use it at in the different countries in Europe to increase our presence. And then we link to the executive, how, like you, Xavier was mentioning, we are coordinating with the executive, and we're also planning to work with the different networks in WONCA Europe, because this is a bottom-up approach. We are researchers and clinicians with a huge interest in improving primary care and have visibility, but also budget. We need money to carry on the research or to have better resources in our clinics. And in order to achieve that, complaining doesn't help. We had to be structured and we had to move forward. And we have a huge motivation for sure. We are doing a lot of things in our free time, thanks to the support of our families and friends. But we also need your structure and your expertise and your guidance to reach the goals that we want to achieve. So that we're very thankful if you can provide any feedback, and we can continue working together in the future, Brussels, Sydney, and online, whatever.
Osden, you seem to want to respond. Go ahead.
Yes. Well, it is very good to see that Sarah and Raquel has just made it, and it's just been a light for the others and for the role model, because that will achieve that people can do that in family practice. The evidence-based data could be achieved in different countries, although they have got different disciplines, policies, and so on. The other part is about money. Yes, you're right. With money, yes, some things couldn't have been done, but without money, nothing could be done. It is another vice versa thing that we should just overcome, and it is so hard because, for example, insulin treatment in Turkey, we are training on diabetes and management, chronic diseases, prevention, whatsoever. And when you just come to a recipe on it, you can't, because the security system wouldn't pay if family physician has prescribed any insulin. So we could write, let me say, 10 years ago. Now we can't. So in rural, let me say, how could the patient reach the health center to get appropriate standard therapy or recipe for this? Question mark. So yes, money is needed, not always, but without money, lots of things couldn't have been done. Again, we are just coming to the evidence-based data, and thank you very much for this. Yes, I'd love to work with you, and it is great to hear from you that it is structured and also have got lots of outcomes.
Thank you. And I think there was also what you mentioned is the management of the resources. And we are very open in our research group. And we have, as Sarah mentioned, 52 colleagues brainstorming together. So we also take into account any feedback. And when they want to present the results in their conferences or make a statement for their governments, we'll also provide support on that. So we are really trying to have the same message, and that's very important to have homogeneity, like Sarah was mentioning. That is, I think, not only across Europe, but also worldwide. We have to put primary care on the agenda, and this is one of the objectives that we are also sharing. How to do that is the nice part, how we can construct using the creativity that Harris was mentioning.
Thank you, Raquel. Sarah, go ahead.
Yeah, yes, also would like to add that maybe the change that we would like to see is going to take, I don't know, 10, 15, 20 years. What I know is I don't care about the change, but I care about what we can do with our hands today. You know, we are not responsible of the answers of the governments, of the main organizations. We are responsible about our answer and how we can advocate for family medicine. And if we want to see change, we have to start moving, you know. And there are many examples in the history about how things changed, and it never changed from one day to tomorrow. It changed from several and several years of committed people who agree about one point, which was very important, and they were together with this goal. So, I don't care if I don't see it in my life, but I'm sure that we're going to see it someday, and I'm really happy to support the next generations, and I'm really happy to give my time. So primary care is everywhere in the world, and every person in this world has the right to have the GP, and they have the access to a very good and quality and very well founded primary care wherever they are. So I think this is our goal. And, if somebody 300 years later, they have it, I'm happy for them.
Well done, and you're an inspiration. Thank you very much, Sarah. Harris, you've got your hand up. Any others where I would like to contribute? Please pick up your hand. Go ahead, Harris.
Yeah, so Sarah and Raquel, thank you very much. That was really, really excellent. That was a fantastic presentation. And I mean, your work is so important. You covered the basic of, you identified the need. So there was a gap in evidence. You are covering that. Now, you mentioned in your presentation different aspects of how different needs for how to reach out to where policies, the places of where policies actually happen, take place. And, it made me think that many other NGOs, bigger NGOs with bigger also, pockets than us, they have in their secretariat policy officers. They have lobbyists, professional lobbyists, who are mandated to go to Geneva, to go to the EU, to go to the regional office of the WHO, and to speak about what is key for the organization. And actually, they are doing that in effective ways. They're doing it, for example, outside the big events, such as the General Health Assembly. They are taking opportunities for example, to go to Geneva during slower times, where they can meet with ministry attachés, and they can actually make a one-on-one hits on their organization's key mission or objectives. This is something that we are lacking, and currently we cannot afford. But it makes me think that we have the power of our network, and perhaps policies may take place, may be decided in the EU or in other capitals of each one of the regions. However, we have also the power of our sort of decentralized network. So by providing tools such as the evidence that you that you worked on, and taking the clear messages coming out of them, by providing a toolkit on communication, on policy, of how what you should talk about, the key points, the key messages that need to be addressed, by providing them to the leaders of the regions, we have the possibility to empower them, to encourage them to reach out to their own local offices, and then make an impact, try to influence their politicians. So somehow we don't have a central strategy in this, but you have, again, the power of preparing at least a more generic template on, let's call it template or toolkit on key messages, and try to leverage our community to help with this.
Yeah, absolutely agree about you. It's a pity that we don't have enough budget to do proper lobby. We would love to do it, I will send my curriculum if you are needing someone, but just talking seriously, I would say that, family doctors, we are very focused on the patients and on giving care to patients, which is lovely. And it's the heart of our work. But, the other part of the work is outside our consultations and our clinics. And then we have to move and think in a broader way because we want the best for everybody. And the best is that primary care is integrated with the health policies in general, and that we have to work and discuss together with our colleagues. So, I would say first, we have a big work inside WONCA to agree that making advocacy for these policies is the right and we must do it. And we have to organize in a better way, I would say, in general. And this is a good way to do it. And, I have all my admiration for Amanda, Harris, Shabir, all of you who are here, because you are actually doing the work. And that's the start of something else. So I would say we have first to work inside, and then we also have to work outside, but we have to improve our strategy inside. I think this is not about Raquel and Sarah opinions. It's about the general opinion of the GPs. That's why we did this study with all these countries, because we realized, we share the same opinion. So why we are not advocating together?
Okay, so thank you. That's exactly, I think, the point of our group. And, to examine the different routes. And you've given us some very good material to work with. So well done on the work too, and the examples of the process. I think that's probably a good point to sort of wrap. I'm aware there's 5 or 6 of us still discussing, but everybody else is still listening. Thank you very much for attending, but also I guess most people have the working day still ahead. So perhaps, Shabir, this is the moment just to tell people who've attended this morning about anything else that we want to share about the group and how they can take the opportunity going forward. And then we will meet again later today in our time to run another webinar. So thank you so much for that. Shabir, do you want to summarize?
Yes, thank you. I think just quickly respond to that, I think WONCA is the WONCA Research Group, Working Party, is working with Anna Dania around practice-based research networks to spread that around the world. And I think you as in your own regions should try and do something to link up to that effort. It isn't necessarily difficult. It is exactly what Sarah's brought up, is let's just bring people, like-minded people together to network and share, and with a view to looking for evidence and then building it simply up from that. I think that will be taken into account. There is also a process of strategy development in the WONCA Executive Committee, and I think these ideas and thinking would surely find their ways there. So thank you for all your sharing. I think in terms of this particular special interest group, we're looking at having we're keeping the process relatively simple, is to have a quarterly workshop of this nature. We want to call it workshop, not webinar, because we want you to actually engage a lot more. So we'd like to keep the presentations a little shorter, but break up into groups. I think what has happened is some useful questions would have been good for everybody to get engaged. And I think it's so much easier for people to just keep quiet. We don't want that because everyone is an expert in this group. I think the other things that we're working on, Amanda, maybe you can share that briefly, is to have a meeting at Sydney for those who are interested as a pre-conference. We do have that opportunity and we thought we'd take it up. And then within the conference itself, that you could, flag your work as part of the special interest group if you think you can submit something to it and be part of this group. I think that might be a great idea. I think for the quarterly workshops, we don't really want to come here and talk shop ourselves. We think that the best way to learn about advocacy is getting people to share their thinking and actually getting people around the table here, each one of us, to reflect on it a bit and to share what we think we would have done differently as a way to build that process, which I think is good for everybody. So I think, please, if you think you've got an attempt at advocacy in your space, even if it is a failed attempt, you tried something and it didn't quite work out, but share with us how you actually found that it didn't work is good enough. But the fact that you said, let me try to influence something, it could be even in your practice. I tried to shift the behavior of an authority on a particular issue like building a park for people and it didn't quite work. I did this, and that, and then let's reflect on it, because that is advocacy as well. So it's not just global stuff or regional stuff. It could be even in your practice. So please feel free to share that. I think every one of us must have some instance of it. And I think this, just send us an email. We've kind of indicated what, you could send a 250-word, abstract, just some documents, and, what questions you'd like to use in the discussion process. Amanda, perhaps you can close with some parting remarks. And thank you very much to all of you, and particularly to Harris, Sarah, and Raquel.
We have a wealth of opportunities. We've also been delighted that so many people have already registered to join the group on the membership portal. And, that's still a work in progress, I know, for the executive, but we've had a number of colleagues from around the world putting their names forward. So that's another place we can, share the information from today and give people ideas on how they could use that in their own place. We've been talking about perhaps providing some outline slides so that people could use those for a training workshop or whatever, with some of the theory in it. Shabir has already, got some set ready. So I think, together we can make a great team at many levels. It may interest colleagues as we close to know, in the first webinar, we had an example from Kuzni in Malaysia, who has been, senior president, regional activist, and he showed some very high level advocacy there. We've had a couple of colleagues from other countries recently saying, I'd like to talk about how we can do this more locally, particularly in countries where they're finding quite a lot of barriers. And so maybe in the next webinar, we could invite colleagues from those different regions and some more with a structure from your talk, Zara and Karis, working with those frameworks to say, so if I'm going to take this forward, or what have I already done in my region, which is the point Shabir was making. Anyway, leave it with us, colleagues. We promise to try to use this excellent input productively. And we look forward to working with you between the meetings to facilitate that. And if anybody wants to join us again later, they're very welcome. Karen Kinder, who, as you may know, has been a very active, advocate with WHO, working in her capacity there, said she couldn't hear the second talk, but she'll join us for your talk this afternoon. So anybody is welcome. And till then, go well and have a good day. And thank you again for all your help and support.
Thank you. Raquel, Sarah, do you mind just sharing your presentations, Harris, and the link to the Zoom recording? And we'll try and put it all, make it available for everybody. Thank you all very much. Bye-bye, everyone.
Thank you. Bye.
Bye-bye all. Bye.